See you soon. So we'll move on to our next agenda item. So we'll be hearing from colleagues across North Central London. So I'd like to say hello to Seher, Jane and Gabriella, who are going to be presenting on real-time surveillance. So I will now hand over to yourselves and we will share your slides for you.
Thank you. Should we start off by introducing ourselves, Seher and Gabriella? So I'm Jane Brett-Jones. I'm a senior strategist in public health, and our department is across the 2 London boroughs of Camden and Islington, which forms part of the STP, which is North Central London. And Seher is also from public health.
I am also a senior public health strategist from London Borough of Barnet. Gabriella, oh yeah, you're there.
I'm here too, don't worry. I'm Gabriella, I'm the suicide prevention leader at Thrive London.
So there are 5 boroughs in North Central London, so it's Camden, Islington, Brent, Haringey and Enfield. And Seher and I are going to talk about the work that we've done within that STP, but Gabriella is going to start off by talking about the real-time surveillance system that has been set up for the whole of London. We've been working very closely with her. So over to you, Gabriella.
Thanks, Jane. I will try and keep this very brief so that Jane and Seher have enough time to go through the work they've been doing in North Central London. But I thought it'd be useful just to provide a bit of an overview as to what Thrive London is, if you haven't heard of us before, and how the system came to be operational. So really briefly, Thrive launched in 2017 with the aim to create collective action across London for everyone to speak openly about their mental health and have an equal opportunity to thrive. What we are is a participation-driven public mental health partnership, is a long way of saying it, across the GLA, NHS colleagues and local authority partners as well, that engages with and responds to the needs and insights of Londoners. Since March of last year, we've been coordinating the public mental health response to COVID-19 on behalf of Public Health England, now OHID and wider partners, with the aim of ensuring that London's diverse communities have the strength and resilience to cope with and overcome unprecedented events like the pandemic. We have a variety of functions supported by different teams in research and evaluation, public mental health comms and programmes, of which suicide prevention is one, and is what I'll focus on for the rest of my presentation today. But Thrive London is the regional lead for suicide prevention in London on behalf of NHS England, and we facilitate the Thrive London Suicide Prevention Group to deliver citywide projects to prevent suicide and support those affected. The next slide, please. So we do this by harnessing some suicide prevention expertise across the array of multi-agency partners who are active in the suicide prevention space in London. We facilitate bi-monthly meetings of a regional multi-agency suicide prevention group that helps steer the suicide prevention projects that we deliver pan-London. The group's comprised of first responders, NHS colleagues, local authorities, as well as the voluntary and community sector. When the group was first put together, it was decided what projects would be best delivered at a once for London level, and that's what's pretty much been behind the development of our variety of work streams in this space, one of which relating to data insights, which is where the real-time surveillance system comes in. So the real-time surveillance system facilitates real-time monitoring and analysis of suspected suicides pan-London, so it's across the entire region, and it helps facilitate collaborative response to particular trends that we see by demographics, for example, or by geography. We're currently expanding the database to try and incorporate data related to self-harm and suicide attempts as well, but it's been a very long and arduous process, so we're still in the process of getting there. The other function of the system is to enable real-time referral of those impacted by suicide to bereavement support, and we collaborate on resources to support those people identified as well, including witnesses of suicide who have historically been under-supported in that space. Moving swiftly on, we have a partnership with Pyrus to deliver suicide prevention education across London, and we recently reached the end of that partnership and we'll be evaluating the rollout of that programme early next year. Alongside that, we have a pan-London campaign to try and encourage the uptake of the Zero Suicide Alliance training, and we have a variety of other pieces of work relating to resilience. For example, as Lewis mentioned, We had some programmes last year which looked at the economic impact of the pandemic and how to support people who had experienced greater financial adversity over the last sort of 12 to 18 months, delivering mental health first aid training to debt advisors and food bank staff as an example, as a way of integrating mental health support within different crisis support structures. But focus today is on the real-time surveillance system, so I will move on to that next. Could I have the next slide, please? Perfect, thank you. So really briefly, the platform functionality. We work with QES who have a variety of expertise in this space in working with very highly sensitive information. The system is populated by London's police forces, so that's Metropolitan Police, City of London Police and the British Transport Police. The submission form is populated predominantly by the host following a suspected suicide, and that's usually within 72 hours of death having taken place. As Jane and Seher will attest, it's been a work of improvement to get to where we are now, and originally those timelines have been slightly longer, but we're now in a place where that typically is within 72 hours of the death. We minimise the mandatory fields as part of that submission process to try and ensure that all fields were completed that were necessary to inform analysis and response, but also minimise the time taken to complete that submission form. But it does enable us to look at incidents, methods and demographic trends. Upon that information being submitted, there are notifications that are sent out to the relevant local authority and the NHS commissioned ICS post-pension services so that they can enact the referral into bereavement support. We also work with other partner organisations to provide supplementary information about the deceased. So that can be, for example, if the individual was known to previously engage with mental health services and how recently they were seen. All of this helps to create an understanding as to the circumstances that led up to their death and help to understand how that can be prevented for other individuals. We have recently started doing reporting on our system now that the data is more complete and consistent, and we provide analysis of it to the Pan London Suicide Prevention Group as well as senior partners who are involved in responding to suicides at Pan London. Next slide, please. I won't spend too long on this because I think I need to hand over to Seher and Jane to talk through what we're doing in North Central London, but just to provide an understanding as to what the system's been used for during the pandemic. The support for it really increased following March last year onwards, just because of the real need to understand real time what was happening in relation to suicide incidents. We've been actively reviewing the data to look for potential clusters as and when they arise and responding accordingly to refer those affected by suicide into relevant support services. And as I've touched on, we recently started doing more regular analysis of the findings to inform short and longer term strategy. Whizzed through that slide, but I realise I've taken a bit longer than I should have. So next slide, please. This was just to talk about what we think we'll do next in this space. So I've touched on this already, but we're hoping to expand the system to incorporate data on self-harm and attempts, to integrate the data that we have with primary care and the prison systems to ensure a more well-rounded understanding of the individual, and to improve the accuracy of reporting of ethnicity, gender identity and pre-existing mental health conditions to inform earlier intervention. I think I'm handing over to you, Jane.
Yes, you are. Thank you, Gabriella. Can we move on to the next slide? And I must apologise for these slides being not at all pretty like Gabriella's. I've been absolutely up to my ears in public health COVID response this week and didn't have time to do very much to them. So this slide should be headed the North Central London Suicide Data and Insights Group. So knowing that this very rich source of data was coming our way from the real-time surveillance system, we already had been working together across North Central London, partly because of the national funding that's been provided to suicide prevention projects at STP level, and we had some funding from that in Wave 1 and Wave 3, which is working across the system. So we'd already been working together on that, and we have a suicide prevention strategy group for North Central London, and we set up a subgroup, a working group within that, which we called our Suicide Data and Insights Group, to be able to jointly look at the data that was coming out of the hub. And you can see there the overall aims of the service. Just going on to the next slide, the people who are involved in that, I've said the NCL Suicide Prevention Strategy Group, so some of the members from that. We've got representatives from each of our 5 councils in NCL. We also have an NCL support after suicide service, so a post-prevention service they come along to the session, and we have lived experience representatives as well. We also have Healthy London Partnership, so usually Gabriella coming to the group, and Metropolitan Police and mental health leads. We've also recently had representation from London Ambulance as well. So we have quite a good sort of multi-agency representation at that meeting. And then just looking at the scope of the group, if you just look at the bottom row, sorry, next slide, we've sort of divided it into something around data quality and governance. So ensuring that local data monitoring and event response, NCL insights and improvement, and impact measurement. So actually, I think the next slide explains what we're actually doing a little better. So around the data quality and governance, we're collaborating with our partners that I mentioned in the group and with Gabriella, partly to give feedback on the actual hub, the way it's working, the quality of the data within it. And that's been a real two-way process, which has been helpful on both sides, I think. Looking at any scope for additional local data to be added to that, and ensuring, I think number 3 there, ensuring correct information governance structures are in place for all the activities of the subgroup, and I would add for the data that is being extracted from the hub. This is extremely sensitive data. It's at an individual level. We're getting narrative accounts. We're getting very detailed information about the individuals who have taken their lives by suicide. And we want to work together really on ensuring that that data is governed appropriately and used appropriately. And I'll say a little bit more about that later. There's a clear benefit for us in monitoring the data locally, both in terms of any immediate response that might be required to an individual or a cluster of suicide. So it could be that an individual suicide uncovers some kind of safety issue in a building, or some kind of access issue that we can address immediately. It has also enabled us to very swiftly start to identify the possibility of local clusters, because we're talking to each other across the boroughs. Obviously, geographically in London, we're not a huge area, so there is a lot of crossover between the boroughs, both in terms of where people live, work, and go to school, but also where they might travel to choose to end their lives. So that kind of immediate monitoring has been incredibly helpful, and we're also trying to develop sort of standardized ways across our 5 boroughs of extracting the data and responding to that. And then on the 3rd column says that developing systems and procedures to review and analyze our data, to think about how we routinely review it, how often we should be doing that at a borough level, at an NCL level, and to try and share some procedures across NCL and be more efficient in that respect. I don't think we've entirely got the answers to any of this yet. We're working on it. The data from the hub has been improving month by month, and the completeness of the data has been improving. But we are beginning to do that, particularly in the boroughs that Seher and I are working in. And I'll just show you some of the results. And then we're also looking in the last column at how we monitor the impact of this and the impact of the outcome measures. So just going on to the next slide, this is just an example. Sorry, that was the slide that I was just talking to. I didn't realise you hadn't moved on. I'm so sorry. Can we go to the next one? So this is just an example of the richness of the data that we can extract from the site. So it's sort of returning to the question that Lewis put, which is, what are the characteristics of those who die by suicide, and therefore what prevention measures should we put in place? So there's all the demographic detail that we can extract from the site, so the things you would expect, the age, the method of suicide, the gender, ethnicity, and those things. But there's also a narrative account which is given by the police which is very rich for us in data. And it's enabled us, this is just one example of an extraction that we've done to look at risk factors that are mentioned in the narrative account. It doesn't mean that it's complete in terms of risk factors, but it does begin to build up much more of a picture of the characteristics of those people who are taking their lives locally. This doesn't represent individual deaths because one person may have several risk factors, but it just gives you an indication of the kind of richness of the data and how it is useful. I just wanted to go back to the governance of the data. So I've put some stars in there because they're very small numbers in many cases. And it is one of the issues that we will be looking at in our next subgroup, is how we are able to present these small numbers in a meaningful way to a much wider audience without overinterpretation of those numbers, if you like. So we have roughly 100 deaths a year by suicide across the 5 boroughs. So very small numbers, and it is all too easy to say, gosh, we had 6 deaths this month and we only had 3 deaths last month. That's twice as many. It's probably meaningless in terms of, you know, being able to make any serious conclusions for it. So that is something that we need to think very carefully about, is how we present this data in more public forums and to people who perhaps don't have the same statistical background as some of us would have, and how we use the information in a useful way without overinterpreting small changes. So I'm going to hand over to Seher, who is going to talk a little bit more about the kind of outputs that we've been looking at.
Next slide, please. Don't have much to say, to be honest. All said. So I'm actually conscious that there are colleagues in the room that they have been working with real-time surveillance systems for much longer than us. We are, you know, our group is still in infancy. But I try to bring to life, if you like, so what we've been doing and how it was so helpful for us. I think starting by, first of all, we were able to send some comments to Thrive London in terms of data improvement. So I better start with that. I'm not going to follow all these slides at the moment. I'm just improvising. But Jane mentioned the locations, and Professor Appleby mentioned looking at the signs. I guess this is what we're doing at the moment. Noting those little signs of locations, methods of suicide, just noting that across North Central London, because one borough is even smaller to be able to make any sense of this small data, and noting those with a view to come back to them and then look at maybe emerging trends going forward. I think this is very important. I have definitely, you know, can say for some of Barnet residents, for example, we don't have any hotspots that we identified in Barnet, but I've noted that some of the Camden parks, for example, have chosen as a location for these individuals sadly taking their lives. But again, this is just a sign, so we need to see how this will go. Methods of suicide, bringing fire service in, sharing this data, and then you know, we started to sort of okay, what are the things that we can do about some of the methods, some of the horrendous methods used, and how we can prevent access to those means, if you like. So we started having these discussions. Again, Jane mentioned cluster. It is about identifying or eliminating if there's a cluster. It's probably more like eliminating, you know, just to reassuring ourselves that, okay, these deaths are not related to each other, that's fine. Or if they are, then okay, we have carried out quite a few informal meetings, just gathering some key individuals together, sharing this data in a very confidential manner, comparing data with CAMS and police and schools, etc. So, and really creating action very quickly. So we weren't really able to do this before the real-time system. The richness of the qualitative data, the contextual data, we're keeping an eye on emerging themes from that context all the time, regularly. We're conscious of that. Access to this data definitely raised the profile of our local suicide prevention partnership. We have GPs, we have schools, we have various council departments that they were interested in this agenda before, and now they are much more want to be part of it. They are coming, so our partnership is growing, which is great. So one of the outcomes that I have observed in Barnet, I don't know, might be the same for other areas. But the most importantly, again, Jane mentioned that we are linking families to our post-vention support service, and not just families and friends, but people also sadly found these buddies maybe in the parks or in stations. So making sure that everyone involved supported because of this this rich data, so we know these individuals. And the final one, again, the last slide, please. We have already discussed the caveats of this data. It is very small. You know, we are unable to make any conclusions about the trends. It is all about noting these emerging signs, I guess. And what we're looking to is just we want to look at sort of aggregating data across North Central London, and we are doing that already in London. I guess that's all I want to say, but I just want to say that this was, you know, where we are now in comparison to 2 years. Is sorry, you know, there's a big shift in attention to suicide prevention, definitely in our local council, and we wouldn't be able to do that without this data. Thank you.
Thank you to the three of you for sharing your progress, and it's great to hear about sort of the multi-agency working that you've got taking place, and also how you've had so many people that have wanted to do something around this, and now you're bringing everyone together and seeing sort of the benefits of that, and how you can then use that data in terms of your post-vention support. And please don't apologise for your slides. We're very lucky to have you presenting and sharing with us today amidst everything else that you've got going on. So please don't worry about that at all. I was wondering if anyone has any questions for Gabriella, Jane or Seher. There's a message from Chris in the chat that they'd be really interested in any examples of structures, you know, governance around data and insight groups, such as the one that you've just described. So don't know, Chris, if you want to put your email address in the chat, or if anyone's got anything that you would like to send to us, we can share that with the rest of the group. Of course, we'll be sharing the slides from today, and Jane and Seher, if you've got any other supplementary information or documents or anything that you think it would be helpful for others to have, then please do share them with us. So any questions? I think as well, it was on your honesty, you know, knowing that you haven't got all of the answers yet. I think that's what this group is for, you know, sharing our challenges that we're all facing and maybe the things that we haven't conquered yet, knowing that others, we're all at different points and might be able to learn from work that's happening in other areas. Okay, Chris has put his email address in the chat, and there's a question from Claire.
Oh, hi, I'm Claire Proctor from Gloucestershire County Council and the Lead for Suicide Prevention there. I was just really interested in what you're saying about the sensitivities of the data, particularly at the stage when you're looking at suspected suicides and some of those softer risk factors. You know, for example, you might get some anecdotal information that the individual had recently had a relationship And just the challenges of handling some of that data when it might be more anecdotal because the death hasn't yet gone to inquest and you haven't had some of those factors confirmed. So it's been interesting for your reflections on that.
Should I jump?
Oh, you go, Gabriella.
No problem. So I think it's an interesting thing to raise. So I guess absolutely appreciate that the data we refer to is for suspected suicides rather than for suicides that have received that verdict at inquest. But I think normally in the contextual information that's provided, there will be an overview as to why or what evidence at the scene led the reporting officer to deem this to be a suspected suicide. So typically, similarly, only factors that the officer deems to have been of relevance in the individual's death will be recorded in that narrative or contextual section. So it's a difficult one. So, for example, when we have done pan-London analysis of those softer risk factors, as you said, I think it's just to interpret any findings or any noted trends with caution, particularly given that relationship breakdown is a very common feature of these types of death. So often that in various forms, it could be familial, it could be your relationship with your partner is broken down. That will be a very common feature. So it's looking at within that factor itself, are there any features that link those cases together? Or alternatively, if there has been relationship breakdown, is there another factor that's also contributed to the death in a particular individual? So I don't know if that's a complete answer to your question. I think it's just more that, as Jane and Seher have said, it's looking at noting what the potential trends might be rather than taking them as concrete indicators.
Brilliant, thank you.
Okay, well, any further questions that come to mind, please do put them in the chat, and I'm sure that Gabriella, Jane and Seher will be happy to answer. But thank you to the three of you once again for sharing your progress today and all the work that you've been putting into your real-time surveillance system. So thank you very much.